Good morning, everyone. We're just gonna wait a couple minutes just to let others trickle in a little longer. But yeah, we're really excited to have you all, and we'll get started in just a few moments. Really quick, before we get started, if you all can take a second and introduce yourselves in the chat, that would be awesome. We just love to hear who's in the room and get to know you a little bit better. Awesome. Well, it's 10:04, and so as people trickle in still, we'll just go ahead and get started with some introductions. So I am not David, if you didn't know yet, but David is not here anymore. We miss him dearly, but Erin and I have decided to co-host the coalition meeting every month, and this is my first coalition meeting, so please be nice to me. I'm sorry if I mess up. But we're gonna do our best and it's gonna be awesome. But yes, I'm Sarah Chalice. I'm one of the outreach coordinators on the Connect-OC Partners for Wellness team. Yeah, just really excited to be here. I am additionally with the coalition meeting co-hosting with Erin. I also am in charge of all our events that we plan and help host, specifically like our resource fairs on various college campuses. So yeah, I'll go ahead and pass it to the rest of the team to just introduce themselves really quickly. And then I'll go to Crystal first and we'll get started.
Awesome. Thanks, Sarah. Good morning, everyone. Thanks for joining us. We are happy to have you here and happy to cover this topic. We haven't covered this topic yet in this meeting. So thank you to Dr. Mario and Jeremy for joining us and being a part of this. So I am Crystal Bleischer. I'm the program director with Partners for Wellness and specifically overseeing Connect-OC, which is our transitional age youth mental health project. We've been doing this for 5 years now, which is kind of crazy. It's gone by pretty quick. So we're happy to have Sarah now co-hosting with Erin. They're both going to do a fantastic job going forward. So looking forward to it. Thanks, Sarah.
Go ahead, Erin.
Well, good morning. So nice to see everyone. My name is Erin O'Flaherty. I'm the Community Engagement Manager for Connect-OC / Partners for Wellness. I oversee the cultural arts and mental health program aspect of our contract, and yeah, I get to work with a lot of different communities, and excited to take on this role of the coalition meetings with Sarah as well. So next month will be my turn, and I'm so excited for what she has to share with you today.
Don't tell them yet. They have to wait.
Yeah.
So, yeah, thanks everyone. Yeah, so just before we get started, if you don't know who we are yet, Connect-OC is a program of Partners for Wellness, in partnership with the Orange County Healthcare Agency. And our focus here is just to educate and promote existing mental health resources in Orange County, with the mission to make them more accessible and widely known to youth and young adults, and those who love and support them. So yeah, thank you again all for being here. I'm going to go ahead and introduce our panel, our our couple of guest speakers that we have with us today. I have Dr. Mario, and then I have Jeremy O'Connor as well. So I'll go ahead and just give you the floor. Dr. Mario, if you would like to start first, just introduce yourself and tell us a little bit about who you are.
Sure. Well, good morning, everybody. My name is Mario San Bartolome, and they just call me Dr. Mario because that last name causes tongue seizures to say. So it's easier to say Dr. Mario. But I'm by training, I'm an addiction medicine specialist. I'm also board certified in family medicine, so I'm boarded on both. I really view addiction medicine as an extension of family medicine, and as was already said, it's like there's those that might have the disorder, but there's also all of those people that love them that are also generally affected. And in terms of some of the, my hands are in a lot of different things. I do see patients through an FQHC in Orange County, KCS Health Center. So I have the privilege of working directly with families and individuals from all walks of life. FQHCs tend to see folks that are on the side of a little bit of the underserved side. Also, a lot of reentry folks from the jails and juvenile hall, and so we get a wide variety of folks. And I also serve as the medical director for Matt Connect in Orange County, which is an organization that's really it's dedicated to connecting people with care, particularly around access to medications for addiction treatment. And so, again, my hands are in a lot of different places. I also have a telehealth. I serve as a CEO of a telehealth company that's focused on mental health and substance use. I'll leave it at that.
Thanks, Dr. Mario. Yeah, Jeremy, if you want to introduce yourself really quick.
I don't know if I can compete with that, Dr. Mario, but I will do my best. Goodness gracious, thanks for being here and sharing your expertise. And so my name's Jeremy. I'm a licensed clinical social worker. I'm the clinical director for California Youth Services. I've been working for Margie Diaz, who's our executive director at CYS for many, many years, but more recently full-time as the clinical director for TAY, kind of an extensive health background, mental health background, as well as acute hospitalization. I worked at ICU, medical surgical floors for about 15 years. I did inpatient psychiatry as well, senior mental health, adult psychiatry. And so I have had the opportunity to work with teens for a lot of my career. And so not only do I do clinical supervision, but I carry my own practice and get to work with wonderful students and teach them how to be therapists, which is a really cool job. So just wanted to recognize too, in my work with a couple of students this week with everything going on around us, there's been a lot of like distraction, difficulty focusing with the fires and just kind of the destruction. So just want to recognize that if we're not totally focused, we kind of get it. So anyway, appreciate the opportunity. Sarah, you're doing great. If you screw up, that's good because then they won't see me screwing up, which will be evident at some point during this conversation. So anyway.
Oh man. Thank you so much, Jeremy. Quick note. I am currently in my on my journey to being a therapist myself. So yeah, I'm really excited about that. So thanks for all you do in teaching students because I am one too. Yeah. So let's go ahead and get started. Just with our presentation. Jeremy, I want to go back to you. Sorry. So can you tell me more about what California Youth Services does in relation to substance use treatment and prevention for youth and young adults?
Yeah, absolutely. Anytime we can kind of showcase what CYS does, it's a privilege. And so if I look down, I have to take notes to kind of stay on point. But the idea that CYS kind of helps kids succeed kind of beyond the troubled circumstances that they find themselves in. So we do that in several ways. We offer multiple programs through, let's say, our JADE classes, which is our juvenile alcohol drug education courses, which is an intervention program. We do our Pathways Community Counseling Center. We do drug testing through high schools. And we also do an alternative to suspension program through Huntington Beach and Los Alamitos, where kids at these school districts who have been maybe caught using substances on campus, drinking, vaping, rather than give them 3 days off and stay at home. We offer opportunities to be educated, understand kind of that there's life beyond using. And so giving them kind of hope and kind of a different understanding of what using does to their minds, to their mental health, to their family relationships, et cetera. So CYS is involved in multiple areas in Orange County, like I said, all the way from Los Al all the way down to San Clemente. So we're touching a swath of Orange County, both adolescent and we do adults through our Pathways Community Counseling Center. And we do try to, certainly connect, and this is a great topic, mental health and substance abuse, right? And the comorbidities between these two things. So, so that's just kind of a little bit about what we do at CYS.
Yeah, that's so awesome. Just such valuable work that you do, especially working with the population that you do, and yeah, making it that importance of mental health and substance use are so intercorrelated with each other, and it's something that people like don't really see much, but it's really important that we acknowledge both of those things, which is really awesome. And thank you for all the work that you do at California Youth Services. So Dr. Mario, with that, can you talk a little bit more about what Through Health is, and just kind of the work that you do there?
Sure. And maybe the more relevant things that maybe as I think about it might be more around the FQHC stuff. But with Through Health is the goal there is to use telehealth and to use technology to break down some of the barriers, particularly around rural areas or places where there's transportation issues. A lot of the reasons why people don't get care is because there's somewhat of a stigma to going to a particular place. And also sometimes there are barriers that are financial. I mean, I've had patients that have to bike through 3 cities to get to somewhere. It's like it's not reasonable. Okay, it's an unfortunate situation. But most everyone has a phone, even the little Obama phone. So I can see people in homeless shelters. I can see them anywhere. And so. And that maybe speaks more to the work that's also done at KCS. So that an FQHC, federally qualified health center, it's a community clinic that we're, and as I mentioned before, I come from a background of family medicine and also I'm board certified in addiction medicine. So there's like the goal is to be comprehensive. And that's kind of a theme, right? Particularly around this age group that we're just kind of discussing here. Really, you can't be reductionistic about what they need. They kind of need a little bit of everything, and because there's so much going on during that time period for them, and they're so influenced by peer groups, they're influenced by family members, they have a lot of social issues that are going on. At KCS, for example, there's the medical aspect, which is very difficult to have access to in general. I think for this age group too, for lots of different reasons, there's some barriers. And we'd like to be really comprehensive, not just only focus on substances and mental health, but you have to realize that these same individuals, as they get older, if they don't die of something like an overdose, they're going to die of some of the types of things that affect people disproportionately around cardiovascular disease and things like that. You can't just ignore those things. And so we try to really, start that process early. And a lot of times you have to realize that when somebody's also using substances, they're generally not taking care of themselves very well. Try to manage an insulin pump on somebody that uses meth. Good luck with that in terms of, managing the diabetic part, unless you take care of that substance part. And then usually, as we'll talk more about today, there's going to be a co-occurring other issue. And that might stem all the way back to some really, unfortunate events that might have occurred in their life that has, set them up and for certain things. So that's one of the, what happens at community clinics, I think across the board, particularly FQHCs, I'll say for you all, that it's the one place where you can't say no. The federal government has set it up so that even if people without insurance, they can't say no. And so that's a wonderful thing. Now, not all FQHCs are set up to provide a breadth of things, but certainly they should help with connecting people. And so in Orange County, at least, KCS really is the tip of the spear, in my opinion, around substances and mental health, because we have psychiatry, we have a bunch of people trained for substance use disorders, and then primary care. optometry, dental. It's another issue, right? People that have a lot of substance use issues, they also have some co-occurring other things outside of mental health, including bad dentition. They can't eat, they have nutrition issues. So anyways, I'll just say that approach from that organization, from KCS, I think is a wonderful thing. And from the standpoint of through health, the idea is get everywhere, and that's the access.
Yeah. Yeah, that is so awesome. Just like allowing access to those who don't really have access to it or are feeling just pressured by the stigma behind it. That's just really awesome that you're able to just provide access and opportunity for those who actually need help and yeah, and all the other work that you do is so awesome. Thank you. So this is for both of you, just to answer, but I'll just throw this question out there. The big question, what is the connection between substance use and mental health? And then another side question of how would even substance use lead to a mental health disorder or vice versa? Yeah, either Jeremy or Dr. Mario, one of you can start.
You want me to start, Jeremy, or you want to? Go ahead. Please.
No, after you, Dr. Mario, please, your expertise is wonderful. I'll just supplement. Go for it.
Okay, so there's a lot of overlap when we discuss things around mental health and substance use. I mean, kind of technically, in the past, we've always viewed substance use kind of as an area of mental health. I mean, it's in the DSM-5. However, we now understand substance use a bit more, and we've through things like improved radiographic, imaging type stuff, that we can now see actually what parts of the brain are affected, and it's clarified some things for us that before, we talked a little bit of throwing around words like stigma, but we used to really kind of think of a substance use as something that is a moral failure. It's you didn't learn it right, or you're just trying to be difficult, and society translated that into criminality. And it was a very specific thing that happened, very specific legislation that transitioned that, where instead of offering people treatment for substance use disorders, we put them in jail or put them through a series of justice system types of things. Now, in some cases, it's very necessary, and in some cases, it certainly can be useful. But the justice system was not really prepared to offer treatment. That's not what it was for. So when we talk about some of these overlaps, in the case of substance use, it's a different trajectory. That's what you have to think about. Even though they're related, they might be first cousins. They don't go to the same exact place. They certainly can trigger. So a substance use can trigger and also worsen mental health in people with depression and anxiety. It can also actually elicit certain things. We have a whole category of things called substance-induced disorders, where, for example, if you use enough methamphetamine, you might go psychotic. And now, is it the psychosis that you have? Are you schizophrenic? No, you don't. You don't have that, but you have a substance-induced. Now, that can also, in some cases, like we see with marijuana, it can precipitate or kind of hasten the development of people that are already kind of genetically predisposed or have other vulnerabilities that give them something like schizophrenia. So it's certainly one can exacerbate the other. There can be, neurochemical changes. Substances do alter the brain chemistry, and that can disrupt mood regulation. We have built-in ways that we normally regulate ourselves. We're not supposed to be even keeled, actually. We're supposed to respond to stressors. We're supposed to feel stressed. We're supposed to go through coping mechanisms of all different sorts. The problems come when those coping mechanisms can be a version of self-medication. And this is, again, another overlap. If certain substances can precipitate worsening of mood disorders, but if you already have a mood disorder, like a depressive disorder, post-traumatic stress disorder, an anxiety disorder, then you might feel the need to self-medicate, to suppress, because it's very natural. I mean, when you're laying in bed and you're in a real tweaked out position, your back hurts, what do? You adjust your position, you cope. That's a version of coping. It's a very natural thing to do. A lot of the underlying things in addiction are quite natural. It's just that what happens is they are disordered because of various reasons. It might be because you were made to cope with some sort of a stressor that you weren't prepared for yet. A 3-year-old is not prepared to cope with violence against them. So they have, but guess what? They have to cope anyways. The body doesn't let you not cope. So when you do develop a coping mechanism, it might be an aberrant coping mechanism, and that you take through your life. And we all know that 50-year-old, 16-year-old. They never quite got out of it. And that's because the scripts, like you're in a play and you have a script, they don't necessarily change them through life for various reasons. So again, there's a lot of overlap, the self-medication hypothesis, and then there's also an increase in vulnerability because we all have an underlying resilience. Each of us have your level, whatever, pick from 0 to 10, you're some number of resilience. Well, when you introduce substances or when somebody has an underlying mental health disorder, that resilience is modified.
Yeah, and kind of to follow up, Dr. Mario, those coping strategies can be really somewhat maladaptive, especially if you're avoiding, right? So if you're using substances to avoid feelings and emotions, right, that exacerbates mental health. And so in my practice, I can see people who suffer from mood and anxiety disorders, but not be using. But oftentimes people who are using more often than not have a mood, anxiety, or some other type of DSM diagnosis, mental health wise, right? So if it kind of going back to kind of early childhood stuff, right? So when I think of like ACEs, right, adverse childhood experiences, I think the CDC website says that 64% of adults have at least one ACE before they were, before they turned 18, right? So, and that's obviously going to affect their ability to manage and cope through really challenging things into adulthood, right? So if we can begin to reduce ACEs, right, we can improve mental health, we can improve physical health, as Dr. Mario talked about earlier. Cardiovascular disease could go down, right? So the question sometimes comes in my mind, so what does come first, right? The chicken or the egg? Does mental health cause my substance use? Does substance abuse create my mental illness, right? And so it probably is kind of dependent on the individual and the experiences that they've dealt with. Certainly trauma and those types of things would exacerbate um, substance use and mental health. So there's so many dynamics that are in play when you're talking about the two. So, but oftentimes in our practice, like at CYS, it's kids who are not really, I don't know any kid that'd be like, I want to go get high or get drunk because I have a severe mental illness and I want to cope, right? Most of it's like I want to have fun and I want to get out of my head and I just want to be with my buddies, right? And so, but in doing so in therapy, we connect like what it is that you're doing really, right? And that is a coping strategy. It is a way to avoid. Avoidance works, right? Don't we all want to avoid something and it temporarily relieves, but then the stress once you're once you sleep long enough, you have to wake up and deal with what it is that's causing the anxiety. So avoidance can work for a certain time, but it's just going to continue to get worse. So anyway, I don't know if I'm going off on a tangent. The question was the connection between the two. But obviously, I think there's a number of ways that they interconnect,
Yeah, and there's some other overlapping things too that are a little bit more on the medical side as well that I'll maybe bring up. One is that they do both have, and they're independent, but there's some genetic predisposition. That's one aspect of it. It certainly does not explain it in the way a lot of people think it. You don't inherit it necessarily in the same way people think, oh, my mom was depressed, therefore I will be depressed. That's not the way it works. Even with things like substance use, sometimes the thing that gets genetically inherited, for example, in the case of alcohol, is your ability to metabolize alcohol. So alcohol, in all, for the body, 100% of the time is actually a poison. There's no actual biological reason to take in a substance like ethanol, which is the actual thing we call alcohol, right? We dress it up, we make it yummy in the sense that we might add a little pineapple juice and we add little umbrellas and we couple it with toasts and celebrations and culture. Every culture, if you go to Russia, it's vodka. If you go to Greece, it's ouzo. If you go to Mexico, it's tequila. If you go to the South, and it's bourbon. Look, we all have these rituals that we have around it, and it's been around forever. We have even when we're talking about things like opioids, but when when it comes into our body, the body has to get rid of it. So if the genetic part of it is that it gets rid of it faster, and this is how we sometimes differentiate, the first time we see it in this age group, actually in adolescence, we have a couple of kids. One of them takes a sip of beer. They go to a party after the football game, and somebody has some beer. And so they drink a little beer and they turn red, get flushed, get a little bit nauseated. They don't feel good anymore. And now they're not, they're going to go home more than likely, right? They're just like, I think I'm going to go home. I don't want any more. Then there's little Jimmy. And little Jimmy, he can down a 6-pack and still be standing and then still want to drive and do whatever he's doing. And guess what? He has an ability to metabolize that. And there's actually a genetic area. There's a part of the DNA that is an allele, it's called an allele, that is responsible for that ability to metabolize. And one group of people, they don't metabolize it very well. So you build up a toxic poison that makes you feel it immediately. And then in the other group, they actually metabolize it quite well. So what happens? Little Jimmy, he's able to put down the 6-pack each time, and he's the life of the party. And guess who his peer group becomes? The other groups of the folks that also do that, and then they start experimenting with other things, because there are some other vulnerabilities that we can talk about as well. But that's where then you start looking at who then, as they develop, become what. And then that one kid that can really metabolize alcohol really well, and you start seeing a pattern of an increase until dependence comes in. Now, using a substance is not the same as dependence, and dependence is not the same thing as addiction. They're all different things. They're related, but once you start using something, and I would say that most people that use a substance don't become addicted. We kind of know that, right? People take a drag of a cigarette, a sip of a wine, they don't become addicted. Then even people that become dependent, grandma has a knee problem. She has an orthopedic a procedure of a knee replacement. For 4 or 5, 6 weeks, she's on a Vicodin, and she became a little dependent. Actually, when we stopped it, she became uncomfortable, had a discomfort to her. But she didn't go and like pull a trick on the corner and go sell her body, or go hit up the 7-Eleven to rob it. She didn't have the maladaptive behaviors and did not express it in those ways. So to get to the point where addiction happens, there's actually a lot of things that do become a lot of dimensions in your life, and a lot of potential vulnerabilities where there's these risk factors. So if we start talking about some of these things in that age group, genetics, although can be one of them, but this age group in general, if we start thinking about brain development, during that time, that 16 to 24, that's when, the susceptibilities are quite high for lots of different reasons. In that age group, the prefrontal cortex, which is the judgment center, it's a part of impulse control, emotion regulation, is not developed yet. It's not cooked. It's in the oven still. So what happens is, if you're going to be exposed to some sort of peer pressure, if you're going to be exposed to opportunities, when you're also developing socially, you get more independent, right? Like when my kid now can he can use YouTube. Well, he gets to the age where he can use YouTube. Now he's one click away from seeing a porn, as far as what he might have access to, right? And so but before a certain age, he didn't have that potential exposure. Well, as independence comes and they begin to do things, they have greater access to environments where substances are used. There's increased likelihood of peer influence. Also, during this time, they have identity formation issues. They're beginning to establish who they are and their identity. That increases exploration and coping. And that means more potential for a substance exploration. And then, of course, during that time, they're a bit, more vulnerable. And that particular period happens to be there's more vulnerability to a substance in terms of its impact when exposed. And that's why we make such a big deal about things like marijuana when your brain is still developing. It's not the same as when you're 50. It just doesn't exactly, impact you the same way. So besides things like genes, there's environment. Already ACEs were mentioned, but stress, trauma of all different sorts do impact it. Forces that kind of etching in the brain that later on becomes a script that becomes an uncontrollable one. And then of course the brain chemistry, like I mentioned, there's a dysregulation in neurotransmitters that are similar. This overlapping area of two in particular, dopamine and serotonin. Neurotransmitters are chemicals that communicate from one brain part to another brain part, or nervous system part. And so when that happens and these kind of very predictable pathways get activated, in the case of addiction, we mentioned the prefrontal cortex. One of the things that happens is it shuts off the good function of the prefrontal cortex. And that's why sometimes we scratch our heads and go, man, little Jimmy just got off a ventilator. He overdosed on some heroin the other day. He's 3 days out from the ICU, and I just saw him scoring some more heroin. What the hell's going on? You know, is he not smart? No, Jimmy's smart. He's just as smart as any other kid. It's not about that. It's just we can't expect the same type of like logic doesn't work in my field. It doesn't work in that sense. So it also becomes one of the things that upsets us. And many of you are providers of different sorts and are in the system in some way, where whether you're counseling or dealing with coordination or providing direct therapy. A lot of times that translates to us getting upset. It's always, I think I was as important that we check ourselves as well. And that's because if your expectation is, I can't believe you're not doing this, why don't you do this? Well, then you're going to go down the wrong trail. You have to start understanding it and understanding these pathways, and then how choices get made so that you can better serve people. But these are some of the vulnerabilities for this age group that are important.
Yeah, I'm really glad that you brought up like specifically just why this age range is so like vulnerable to substance use disorders or mental health or mental health disorders, like just based on it's not just like, I mean, yeah, it's like social impact, it's environmental impact, but it's also neurological, and it's like affects the brain and it affects so many other parts of um your being that it's just, yeah, it's really important that we take that special care, especially in this age group. And just really, I really value that both of you brought up the use of like childhood experiences. I think that's really interesting just to point out, just because substance use and mental health disorders, they don't just happen. Like you wake up one day and you choose substance use disorders or a mental health use disorder. And that is just something that's become a coping mechanism that people have brought from childhood. And that is it just like opens up this whole can of worms for me of just like, what does that look like of us having to try to figure out how do we treat it at the core, but also like explore so many other avenues of how we got here, or what happened, or what's going on, and how do we move on, or what treatment do we pursue further. Yeah, I just really wanted to point that out again and reiterate that that's so interesting and just so cool, just to hear just a different perspective that I may have not have even heard in that realm. But yeah. um yeah, so let's talk. I kind of want to talk a little bit about treatment wise. So, if somebody that you're treating has a co-occurring disorder, this is, you can answer, both of you can answer this one. If you have it, does that complicate treatment, or even recovery? What does treatment look like and recovery look like for someone that may have like a co-occurring disorder?
Well,
You know,
go ahead,
go ahead,
Jeff.
Dr. Mario.
No,
Go
go
for
ahead.
it.
Well, so I pretty much for me at these days, almost every time I'm treating somebody, it's co-occurring. I mean, I almost just don't see it not be co-occurring. I mean, it might not be fleshed out or developed or as, impactful at the moment, depending on their age. But I've had, you know, kids 10, 11, 12 years old shooting chemicals that are patients. It's not as common, right? But as you get into the 15, 16, 17, and there's different things that are happening, um, really, this is where we get into this kind of, you have to imagine almost this Venn diagram of family, community. And if we start thinking about treatment, sometimes treatment might involve medications. Sometimes treatment might involve the need for a safe space, where sometimes we have to actually put people in particular types of settings, right? And we have, in the world of addiction medicine, we have this thing called ASAM criteria. And most of you probably have heard of something along that line, but ASAM stands for the American Society of Addiction Medicine. And they have it's a system, it's a rubric of viewing patient placement as well. So we can look at, well, what are the characteristics for this individual and what they're struggling with, whether co-occurring or not, and what sort of a setting do they belong in? Is it IOP, intensive outpatient? Is it PHP, partial hospitalization? Is it a residential treatment level? Is it one that has more medical? So if you have somebody that has a dependence to alcohol and has had a history of seizures, it's not appropriate to just go kind of like, we'll see what happens. Let me hand you this Bible. You can go, read the Bible, make it not appropriate. That person could die. And I mentioned before that I do quite a bit of medical legal work. I've served as as an expert witness for these cases where, unfortunately, a lot happens in this age group, where they pass away. And part of it is part of the reason they pass away is because as a society, and this includes, the docs that are out there, my colleagues, that we're too afraid to actually intervene as on the medical side because traditionally we've always said, well, just therapy stuff or just, they need other kinds of things. Where the stakes are different now. Even 10 or 15 years ago, it was a little bit different. I mean, we didn't have things like xylazine, we didn't have fentanyl. You don't have to even be addicted anymore to die from an overdose. You could just be pure poison. You thought you were using MDMA because your friend said, hey, try this and we can go touch each other and blah, 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 blah. And it's all fun. And you go to it. And then next thing you know, that has fentanyl in it. And you're opioid naive and you die, you stop breathing. And so now we can look at the concept of treatment by reverse engineering what are the protective factors and prevention. Number one, strong family and community support. We need that. Okay, let's kind of list them kind of first, because these are always going to be part of what we consider to be treatment. And Jeremy will probably have a lot to talk about some of this stuff. The second is positive peer relations. This could be both from people with lived experience or just having positive people around you. A third being access to mental health education, resources, and treatment. You have to have access. This group tends to not ask for treatment. They're not the first ones to go, you know what, by the way, can I see a psychiatrist or a therapist or a counselor? They don't do that. Typically what will happen is they'll get in trouble and then they'll be forced in some way. And then I'd say the last one is they also need skill building, skills training. They need to actually feel the idea of some success in their life in terms of building this over time. That's how you kind of get out of the hole. All of those together are always the recipe really for like these. And if you see somebody with any of these, you can consider them protective factors against mental health issues and against substance use disorders. But treatment can be really complicated. And unfortunately, we don't do it very well in the United States quite well. And I'd say Orange County, we have even more challenges because we don't have a traditional county system like say some of the other surrounding cities, right? We don't have like a county USC or a baby county like a Harbor where people can go no matter what. So we have these other kind of a patchwork of how we do it. So we have other where people can access care can be a bit difficult. But let me stop there and let Jeremy maybe talk, because I think the aspects around community support and those peer relations and the counseling and that system is so important for both treatment and for prevention.
Yeah, that's awesome. Thank you. Jeremy.
Yeah, thanks, Dr. Mario. I mean, there's so much packed into all those things that you really just said. And so like one of the parts of our JADE program is for our participants to listen to parents who suffered a loss of a child due to substance. And fentanyl, the increase of fentanyl death is just remarkable. If you look at a graph from where it was 10 years ago to now, it's just such an upward trend. And so where when I first started in the field, it was, kind of like just say no, it's dangerous. And now it's like if you use, you're going to die. So it's just a different messaging. And so you're right, Dr. Mario, the community makes such an impact on these kids. And so like at CYS, what we're trying to do is intervene, because some of the parents, many of the parents, I should say, are kind of got their head in the sand, not my kid. That doesn't pertain to me. And so when they start getting exposed to a dirty drug test that their kid is testing in JADE, and like, oh my gosh, I never knew. And so now we're exposing them and their need to be a kind of a change agent in their kid's life. And so CYS mandates parental participation or guardian participation because they are such an instrumental part of their kid's recovery, So, and kind of going back to, kind of the way the brain, kind of works. And Dr. Mar obviously is the expert. A lot of I love Dr. Dan Siegel. I love Dr. Gavin Mate. They talk a lot about like the upstairs and downstairs brain, the amygdala hijack of the upstairs to the downstairs brain, right? And so a lot of the kids, recognize this distress that they have in their life, but they don't connect that, like it's like something happening in my brain, and my amygdala is hijacking my ability to think clearly, and so I have this fight or flight, right? And so our kind of a main responsibility I think we have is to kind of just a psychoeducation. This is how kind of your brain works. And, when you talk about implicit, explicit memories that, Dr. Mate talks about in some of his books, like Scattered Minds, for example, or Whole Brain Child by Dan Siegel, right? So you got these kids who react and don't know why they're reacting, and then they cope to kind of just calm some themselves down. So, but we need parents to manage their emotions so then they can help co-regulate their kids, right? And so many of the parents are like, how do I, my kid's out of control. Well, how are you reacting to your kid being out of control? You need to begin to manage your emotions and model and kind of help kids see that you're not mad at them, you love them unconditionally, right? A lot of the therapists we talk about in supervision is unconditional positive regard, right? And kind of this old school idea that you need to know that you're loved, and there's nothing that you can do that'll make me love you anymore, and there's nothing that you'll do to make me love you any less. And so many kids that's absent in their lives. And we as parents, we're totally distracted with technology, phones, the dopamine hits that we look for, right? So many kids are seeking that, right? When you talk about brain development, like Dr. Mario was saying, that prefrontal cortex doesn't develop till 25. And so what dopamine hits that we should have through sports or working out or through other like kind of normal activities, man, these kids are using marijuana that's made in a lab essentially, and the dopamine response is so huge that like to get a normal dopamine hit's like nothing. I don't want that. I'm searching for this, right? And so then parents don't know what to do. So anyway, um maybe I should go back to what we do at CYS, going off. But yeah, I love the idea of community. That's kind of what we do. We connect these kids to, like, we have a panel of sober teens who's come into Jade in our alternative to suspension programs. These are young adults, late teens who have work sobriety. We're a 12-step based program. We want them to understand there's life in sobriety that's positive, that you have purpose, that you have meaning. These kids sometimes lack so much of that purpose and meaning in their life. They are connected to this peer group that gets drunk, and like what purpose is that? So we talk a lot about health. I talk about like kind of the three tenets of health, right? Physical, emotional, mental, emotional, and oftentimes we discard the third, which is kind of that spiritual health, right? What is, like in the 12 step we talk about like higher power. What is that? What do you have faith in beyond yourself? Right? And where do you find that ultimate kind of purpose? So we talk about those three things. Sometimes that's kind of a concept for parents and kids as well, because it's just not talked about enough. But appreciate what CYS does, and kind of what all of us do, right, is interconnecting community and those positive influences to change really the brain chemistry of these kids. You're trying to create neural pathways that are healthy. So, and you can only do that with a community of people that love them.
That's
So,
awesome. Dr. Mara, did you have something
Yeah,
to add?
you mentioned as well about the parents, and I think there's another point in there too that I think is important. When people develop disorders, it's almost never in isolation. So, when we talk about, say, family members, parents, guardians regulating themselves, you have to realize there can also be lots of other underlying issues. If if they themselves are not resolved in some of their things, it's very common to essentially recreate it in the people around them. Sometimes you can't. There's nothing you're going to do to really impact it too much. You have somebody with a personality disorder, narcissistic disorder, with or borderline that is just untreated, not open to that. Sometimes what you have to do is to actually figure out ways to help somebody set boundaries to not have that person participate. And there's plenty of times when I am in a room and I have to ask people to step out. Whether it's a spouse, or whatever. And it doesn't always show up in like a domestic violence or abuse that way. It could be very subtle. It could be very subtle, but it becomes a point of inhibition to progress for an individual. And so you have to be very aware and attuned. And so what we also offer folks that are like parents and others, those that love the individual in some capacity and they're in their life, is they have their own journey actually in the process. That's completely independent of what this other individual might do. So we have to say, hey, whatever Jimmy does has nothing to do with what you do in terms of how you're going to need to address some of the things you have to address. And you might need to introduce them. And there are things like, along the line of Al-Anon, and there's other things that are along that line where they have to begin to explore their own way of being. It doesn't even have to be a pathology. We don't have to pathologize this, but whether it helps or doesn't help, just that's enough. And that can help sometimes in trying to figure out for kids, because sometimes they also don't forget, even when a parent may have righted their direction. If the damage was done early, they may not, the kid may not forget. They may not forget into adulthood. They might find themselves as a 50 or 60-year-old. Sometimes I have these discussions where they still have not forgotten. They have not forgotten. And so those things all need to be addressed. And when we talk about co-occurring disorders, it is important that if you see something that's maybe outside of the scope of what you normally are doing, that you're connecting them with the appropriate people. Sometimes, and again, we sometimes hesitate to think about things like medications and things like that, but there is a group of folks where it can be useful at any of these ages. I do, for example, one of the things that I do is provide access to medications for addiction treatment. There are some FDA approved medications. They're not for everybody. And almost always I would say that the non-medication stuff is almost always needed. I mean, I can't imagine a situation where I'd say, well, appropriate counseling and support. It's like, yeah, you definitely need that 100% of the time. Then there's some of the time, there are also some medications like buprenorphine for people that have opioid dependence, not just that have tried opioids in the past. That medication does save lives. It can decrease the likelihood of overdose by up to approximately 80%, depending on the group. We have seen that with an expansion of that use. Guess what? In 2022 and 2023, we've seen the first drop in the age group between 15 and 24 of overdose deaths. We went from 15.1 deaths per 100,000 to 13.5. That's a good direction, right? I mean, we were only going, Jeremy mentioned the graph. That graph sucked. That graph was going up like this. And in some things, we're still learning they are. So whereas highly potent synthetic opioids like fentanyl have driven the curve, right now, guess what's popped up that's now driving the curve? Stimulants, psychostimulants. So now what we're seeing is, if I were to show you the graph and that Jeremy's talking about, and it goes like this, almost straight up, that's the fentanyl from about 2014. It goes straight up like this. Now over here, we have, if you do it by substance, we have another slope of the curve going up here, and it's with methamphetamine and cocaine. And some of it has to do with the where the substance itself is tainted with fentanyl. It's in combination with kind of a situation, but that's the reality of now. I've had the first person in this age group in the clinic in Orange County now that's also been exposed to xylazine. Xylazine is an animal tranquilizer. It's it's for hoofed animals like moose. But it's been around for 20, 30 years, and in places that originally started in areas like Puerto Rico, and then it flew over to the East Coast. The East Coast has done a bunch of stuff with it. If you ever want to learn more about xylazine, look at what's happening in Philadelphia. They've had more time with it. They were nice enough to give us xylazine, and it made its way to us, and we were nice enough to give them methamphetamine. It came up from our end all the way up to the east. So we swapped substances, but if you look at the map of the United States, you can kind of tell, even by age group, what are people dying from or being hurt from? Because each of these, we didn't talk about the other comorbidities like hepatitis C, HIV. We didn't talk about endocarditis. These are all things that in my world then become an issue, even at young ages. They're 20 years old now with hepatitis C. and we have treatments for those things, though. This is why it's important to take care of. But sometimes they need it in conjunction with other medicines. There are medicines that act like opioids, like you are all probably familiar with, like methadone. But then there are also ones that are opposite of opioids, like they're antagonists, like naltrexone, that are all FDA approved to be a blocker, to help people not die if they do happen to become exposed to a substance. And there's some that we don't have great treatments for, like, you know, ketamine, GHB, even I would say even things like marijuana. I mean, we don't have a lot of great pharmacotherapies for those. Those are going to be primarily going to be from the standpoint of uh, psychological type therapies and modalities. But it's, the research is growing, and at the end of the day, you have to treat both a mental health issue and a substance use issue if you're going to get anywhere. You can't ignore them.
Yeah, that's crazy. And yeah, it's the graph for me, of just the rise in the drug, and then another drug comes and takes over, and it's just so overwhelming. But I just really appreciate your valuable insight, on the topic, both of you. I think we're gonna actually end with one last maybe question, maybe one or two. But I just wanted to ask, like, what does the role, of culture come into play? So are there any specific cultures that are more, who particularly struggle with, co-occurring disorders, or substance use even? Or are there any unique challenges for certain marginalized communities? Yeah, I'll just leave it open to whoever.
Yeah, certainly, we take cultural considerations when we do treatment, right? And we have to consider, I mean, here at COIS, I mean, we can work with a poor socioeconomic family in Santa Ana to multimillionaire kid in like San Juan Capistrano or San Clemente, right? And anywhere in between that. And so we have a large Hispanic population that we work with, especially in our school districts. And so kind of how does maybe a Latino family influence the family dynamic to where now their kid is struggling to what is a multi-million-dollar family and the entitlement maybe that kid has. How does that influence? Is that those Western culture type things? So I couldn't say I have like statistics necessarily on cultural things, but to be cognizant that cultural plays a huge role because really it's kind of their worldview, right? That culture obtains a worldview through, their generational experiences, right? And that's just kind of passed down generationally. So anyway, I'll just say that, yeah, it's a huge consideration when we look at how that might affect treatment, where some families see mental health treatment as very shame-based, right? And it's shaming for me as a parent to have you go into treatment. And so versus a family that is very open to treatment. So there's a kind of a vast array, but maybe Dr. Mara, you could probably speak some of that better.
Yeah, there are a lot of cultural considerations that have to do with treatment. One of them that I think has to do a lot with just the idea of, does it even exist? And I've dealt a lot with this, where you say, what do you mean he's addicted to something or has depression? In my day, we didn't even have that. What do you mean? Just like we're kind of hearing a lot of folks also around the discussion around autism and other things that are around that line, where it's like people kind of think, oh, it wasn't around in my day. But so there's a lot of education that needs to happen for those folks to help the process of treatment happen, and make its way through. And the part that's important too is, like, I mean, there's another cultural aspect that has to do just with exposures. If you were to put out like by ethnicity, for example, I mean, there's lots of different ways to view culture, first of all. So it's not a simple question, but if you were to view a graph and look, there are groups that have a higher exposure or higher representation in particular substances, not all. Okay, so you can't say something like substance use disorders. For example, there are certain types of communities, if they're first generation or kind of like the original generation that's coming from, say, another country, they have actually different risks. If we go to like parts of Asia where alcohol is like, Korean population, for example, is very high. It's one of the highest of all Asian populations, but when you get to the US and you're looking at the second, third generation out, they begin to look different. And also, and I see a lot of good comments in the chats here as well about kind of this concept of activities and things like that. And I think that that's another area where culture comes in, because in some communities, things like church become very, very significant. In fact, just to kind of follow with the one of, say, the Korean culture, the church is just it's an everything type of thing for some community. They all know each other. They all help each other. They're sources of support, but there can also be sources of judgment. And so culture can be very, very complicated. But I think that I definitely, these with the comments here, I think that the more, and that speaks to the community, right? Community can be looked at from a lot of different angles. And some cultures, and depending on where you're at geographically, can lend itself to being a source of support for some groups, and then and others, sometimes not. Like, I've had cases where we've had folks that maybe they're Muslim. They don't want to tell their family. I have no way to engage another family member. They feel like actually potentially threatened, and so we have to do things in secret sometimes. And it's just the way it is. Obviously, confidentiality is an issue, and culture can be. These are important considerations, and you have to get to know. You have to get to know your family. You have to get to know who you're working with. And that maybe is a good way to kind of say this whole thing. At the end of the day, we talked about a lot of overlapping things, a lot of patterns, but really at the end of the day, it comes down to what that individual experiences for that family and for that individual, for what they're experiencing. It's not all the same. They don't all experience the same type of things. But understanding kind of where the roots are and kind of how they overlap does help all of us, I think, to do the right thing, to provide as many pathways to recovery, which sometimes when my patients ask, well, what are we after here? Are we after not using drugs? I say, no. What we're after here is quality of life and safety. Safety being don't die of an overdose, right? But quality of life. And how do you define this? So what is quality of life? So, well, I'm not going to bore you with like the academic way. Academics look at it, well, what are the quality of life years and this and that. No. Let's make it simple. Quality of life is, are you in a position to love and be loved? That's it. And when you're in your disease, and whether there's a substance use issue or a mental health issue that's not being addressed, you can do neither very well.
That's awesome. Thank you, Dr. Mario. I was actually gonna finish off our time together with like that community question. So I'm gonna point it over to Jeremy really quick. Jeremy, do you have any insight into like alternative groups or things that you have seen that have helped?
Well, I'm a little biased. I would say 12-step group, because it really, especially like for our young people, there's a AOKIPA, All Orange County Young People's Alcoholics Anonymous. And these are young people who are serious about their sobriety and actually want to improve that quality of life, like Dr. Mario says, right? But that kind of goes back to the question of like physical, emotional, spiritual health. Some of the comments, which are great, you're looking at all kind of three of those aspects, whether it be through sports, whether it be through church and that spiritual growth, right? And like nutrition, all these things, you're looking at how to balance that. So whether it be 12-step group, it might be a church, it could be Boys and Girls Club, why not? But really, I think it has to start really with the family dynamic, ultimately. Like Dr. Gabor Mate would say in Scattered Minds, is like the goal is not to create a compliant child, right? Like when we see parents in therapy, like if only he would change X, Y, or Z, like life would be good. Well, that would probably decrease your anxiety, Mom, if he did all those things that you want him to do. But really, the goal is to develop character, right? And that's ultimately what we need to do, and even in our own specialties, right? We are that community too that you're talking about, right? We each have the ability to touch that particular life in such a positive way and speak truth into that young man or woman, right? So what we want to do is be that instrument to be able to do such a thing, right? So, and if you need, like, CYS is a great resource as far as plugging in. It kind of depends on the circumstances, right? That adolescent needs. Maybe it's something that the parents like need because the child is just completely out of control. So now I need my own support group. So really, we can kind of plug adolescents or parents into specific groups depending on what the needs are. But anyway.
That's awesome. Thank you so much. Yeah, and with that, I think we'll finish off just on that note of just the community aspect of it and how just there's so many aspects of community to provide support to people who are struggling with this issue. I just wanted to say thank you to both Dr. Mario and Jeremy for your insight. I was truly soaking it up like a sponge. So awesome what you guys all do, and just really value your time and your knowledge and experience with us, and yeah, we really just appreciate it all, and it was such a good conversation. I wish we could keep going, but according to time we'll have to wrap up. But yeah, I will we'll go into a time of programmatic updates on our end. And so maybe I'll pass it to Vivi, who I forgot to introduce. I'm so sorry, Vivi. You're the best. If you want to introduce yourself really quick and talk a little bit about some of the updates that you have for us.
Hello, good morning. No, it's okay, Sarah, first time nerves. But yes, I'm Vivi Vu. I'm one of the outreach coordinators on ConnectOC team. I mostly focus on social media marketing. So any of the social media stuff and newsletters you'll see, that's me updating you. So reach out if you want to share any events you want me to share. So one thing I wanted to share is that from February, I guess 9th to the 15th is Random Acts of Kindness Week. And what we're doing is a social media campaign where we're sharing every single day how you can be kind in specific ways. So some of it can be kindness in the community, kindness in the home, kindness in school. And we're going to share stuff like that. So I really encourage our partners and everyone who is connected to our social media, which is on Instagram, which is at connect_OC. If you guys can share any posts if possible, interact with our stories, that'd be wonderful. On top of that, we're also collaborating with APIT and Latino Health Access. We're going to be having events with them. So more information about that will be sent out and posted as well. So yeah, thank you.
Yeah, and then I'll pass it to Erin, who just if you want to touch on our Hope Stone campaign that's new and just any art workshops updates for you.
Awesome. Yes, so we're working on our Hope Stone campaign, which has been really well received within a lot of the groups that we work with. We work with a lot of foster care organizations and domestic violence shelters, homeless shelters that serve transitional age youth. We work with veterans and the LGBTQ community. And in creating these stones, we are also sharing the really important vital information of sharing the 988 crisis lifeline number. And then on the other side of the stone, sharing positive messages and then placing those in trails and parks, college campuses, high school campuses, and just sharing that innovative art presentation paired with mental health resources. So excited to keep sharing more information on that. And there'll be more information on our social media as well. And then I also just wanted to highlight that I've been working on an event with Coastline College for February 21st, in which we are having veterans that are college students and also just any college students come for an amazing opportunity for a resource fair for mental health, and that we also are providing free workshops in which we're creating the Hope Stones and acrylic painting on canvas and painting ceramics, and then there's free food, there's music. It's going to be a great event. So my email's in the chat, and just please let me know if you'd like more information. Thanks, everybody. Oh, also an amazing presentation. That was incredible. I took so many notes. So thank you to Jeremy, and I think Dr. Mario hopped off, but yeah, that was incredibly insightful.
Definitely. Yeah, I think we can just open it up to any community updates. So if any of you have any updates that you want to share with the rest of us, feel free to unmute yourself. Yeah.
There, this is Leslie with the City of Mission Viejo. Yes, very interesting. I took a lot of notes too. Thank you so much to the presenters. Just want to update everybody that we have updated our drug prevention and resource guide. I talked to Crystal about getting that out. What we do at the city is try to identify resources in our local area and address them the best we can. And how we do address them is we have town halls and forums periodically. We do have one planned May the 14th focusing on cannabis and particularly gummy bears and what's occurring with that. Our guest speaker is Joe Eberstein, who many of you may know, and he will be speaking on that. We also are going to address the fentanyl crisis again with a youth Narcan training. We had that approximately 8 months ago, and it was incredibly successful. So we'll be doing that as well. But at any rate, we've got this brochure. I did have a question, however. We're trying to get the best resource for Matt. Where would be a good email and or website for medication-assisted treatment that we could add to our resource guide? Does anybody know? Would that be the doctor, perhaps? I know he's mentioned it. At one point, we had a connection with the county, OCC.org programs, and there was a brochure related to Matt, but that website is no longer operational. So I'm wondering if anybody would know.
We can follow up with a few people on that too, Leslie, and try to get back to you because that's a good question.
Yeah, kind of.
Yeah, we will. This is Rubina Rao with the Orange County Healthcare Agency, and thank you for that. And I will actually, if you are able to send me an email, I will forward it to my colleagues in the substance use department division, because they do pretty actively are engaged with Matt in the community.
Okay.
I'm just not familiar with the the rules and the policies, etc. So what I will do is if you send, I put my email in the chat after my comment, and go ahead and send me an email and I'll forward it to the right folks.
Very good. Great. Thank you.
Mm-hmm.
Thanks, Bhuvna.
And
Yeah.
I also wanted to quickly throw out there, we have our community suicide prevention coalition meeting on the 15th. I was actually looking at the date and time. It is on the 15th at 9 a.m. and we'll put details. Actually, we'll send it out to Crystal and Sarah to forward it to anybody who might be interested in participating.
Definitely.
Yeah, thank you.
Yeah, of course. Thanks. Lisa, I'll go to you.
Perfect. Good morning, everyone. Hi, Sarah. Thanks. I just wanted to introduce myself. My name is Lisa Nino, and I am the Senior Operations and Clinical Services Manager with Thrive Together OC. So just quick plug for our services. All of our services are at no cost for Orange County residents, and our focus is helping identify young people aged 12 to 25 who may be at higher risk for more serious mental health conditions, including psychosis. So some of our services include brief screenings and specialized assessments, including the structured interview for psychosis risk syndromes, or the SIPs. We also have community education and trainings. So I will drop our menu of trainings in the chat. Our next live virtual training is called Partnering with Schools for Youth at Risk for Psychosis and Their Families, by TTOC's co-founder and UCI's CHRP for our clinical high risk for psychosis expert, Dr. Jason Schiffman. That training is going to be on January 22nd, 2025 from 12 to 1. We also have a virtual training library called Rockstar Learning, where all of the pre-recorded trainings are available. That's at no cost. We have consultations for individuals, families, and providers. So what I'll also drop into the chat is our drop-in clinic flyer, which is every Tuesday from 10 a.m. to 2 p.m. We're located just down the street from the block in Garden Grove. And then we also have short-term clinical interventions while we're referring and linking with the right level of care. So I know that Dr. Mario, that was one of the things he mentioned in as part of the panel, is really just making sure individuals are linked with their appropriate level of care. So I wanted to share that too. So I'll be dropping those in the chat, as well as my email if you have any have anything else. I know our training and outreach coordinator, Sierra Martinez, she usually attends these, but she wasn't available today. And so in addition to myself, we have one of our clinicians, Araceli Velez, here on the call. So it's great to see everyone. Thanks, Sarah.
Yeah, of course. Thanks, Lisa. And then I'll go to Ashley.
Hello, I'm Ashley Frutis. I'm a case manager and past participant for Ready Set OC, and our program focuses on skills education and training. So mainly like education and employment. We help our clients get to their goals through that, and the program has helped me in many ways. Obviously, now I'm a case manager, and then I was able to get help with my education and employment as well. So I think it's a great resource for many different clients, for different students, because we do help kids and focus on kids with barriers. So these barriers could be like different types. It could be mental health, it could be a disability, low income, homelessness, anything like that.
Awesome. Thanks, Ashley. Does anybody else have any just program updates that they want to share? We do have a few in the chat, so thank you for throwing those in the chat.
I think I want to just mention that the State Council is having its open house. And for those who worked with Christine Tolbert before, she represented the disability community. And there are people, for instance, with autism or other developmental disabilities that are susceptible to influence in terms of substance abuse. And sometimes when that piece of it, let's say the autism is not diagnosed or treated, it can make them especially susceptible. So I want to make sure that this community is aware of what the SCDD does, and we connect families with the different state resources, either in the healthcare or the school district or the job placement, something that can help the families get treatment for the untreated autism or the diagnosis. So we have a virtual open house. So please spread that among your partners, and so that they can be aware of that if they have the time and are interested.
Yeah, of course. Thank you so much for sending that information. Yeah, I think we will, with the meeting summary, we'll definitely send out just any flyers and stuff that you all have for us, just to send to our communities as well, so that everybody has them. And lastly, if you would love to take a survey for us, just about the presentation, the meeting, and if you have any recommendations for future meetings or things like that, please feel free to take the survey. Crystal put it in the chat. So yeah, we really appreciate all the feedback that you can provide for us and ways that we can improve ourselves. And yeah, if you're willing to do that, please do that as well. But with that, our next meeting is going to be February 14th. So come spend your Valentine's Day with us. I know that's exactly where we all want to be. It's going to be so much fun. And yeah, so we will hopefully see you February 14th for our next meeting. Please take our survey. Yeah, have a great Friday and a great weekend, everyone. Thank you.